I want to discuss the effect of contractions. The placenta floats on a lake of blood called the intervillous space. This lake contains several hundred cc's of maternal blood at full term. The blood is deposited in the lake by open maternal arteries and is drained from the lake by open maternal veins. During a uterine contraction, blood flow through the uterus slows because the maternal vessels are being compressed by the myometrium. If the contraction is strong enough, all blood flow through it will stop. Thus, with each contraction of any significance, there is initially reduced flow to the intervillous space, then a cessation of blood flow, followed by a gradual resumption of blood flow. On one level, you could imagine the danger of the fetal oxygen supply being interrupted by each uterine contraction. But on another level is the realization that for a normal fetus, this interruption is nearly trivial, similar to holding your breath for 5 seconds. But if the contractions are coming too frequently, with very little time between contractions for fetal resupply, or if the fetus already has a significant problem, then contractions can pose a threat. Periodic heart rate changes are those heart rate changes that are recurring through labor. They are typically associated in some way with uterine contractions, and there are 3 basic recognized types: early decelerations, late decelerations, and variable decelerations. Each has its own features and clinical significance. In addition, a fetus may demonstrate combined decelerations, for example, the severe variable deceleration with a late deceleration component. Early decelerations are periodic slowing of the fetal heartbeat, gradual in onset and gradual in recovery, and synchronized exactly with the contractions. These dips are rarely more than 20 or 30 beats per minute below the baseline, but last at least 30 seconds from onset to nadir. These innocent changes are thought to be due in many cases to fetal head compression within the birth canal. But some patients demonstrating early decelerations will later develop variable decelerations. Late decelerations are repetitive, gradual slowings of the fetal heartbeat toward the end of the contraction cycle. From onset to nadir, they last at least 30 seconds and have a gradual recovery to the baseline. They are felt to represent some degree of uteroplacental insufficiency. All blood flow in and out of the intervillous space stops briefly during a contraction. A normal fetus with a normal reserve, in other words oxygen in its bloodstream, in the blood of the placenta, and in the intervillous space, will probably not notice the tiny drop in total oxygen availability during these contractions. But a fetus who has used up its reserve, or who cannot maintain its reserve, will, over the course of the contraction, develop some degree of hypoxia, hypercarbia, and acidosis. This otherwise normal fetus will respond by slowing its heart rate to conserve energy. The fetal heart rate is the largest consumer of oxygen in the fetus, and if the rate can be slowed, the fetus will survive longer on less oxygen. After the contraction passes and fresh blood resupplies the intervillous space, the hypoxia, hypercarbia, and acidosis is eased, and the fetal heart rate returns to normal. Clinically, the development of late decelerations is a worrisome sign that the fetus has very little reserve. Techniques that can be used to correct this problem include changing maternal position to improve uterine blood flow, IV hydration to increase maternal blood volume, presumably leading to an increased uterine blood flow, administration of oxygen to the mother to try to get some additional oxygen through to the fetus. Of these 3 standard treatments, oxygen administration is the least helpful, since the maternal hemoglobin oxygen saturation is likely already about 99%. The effect of breathing additional oxygen will probably have minimal effect on the oxygen saturation. Other techniques include decreasing or discontinuing oxytocin infusion to slow down or stop contractions that are provoking the decelerations, or administering tocolytic drugs to slow down or stop contractions that are provoking the decelerations. If the late decelerations are persistent and non-remediable, this is considered fetal distress, fetal intolerance of labor, or a non-reassuring fetal heart rate pattern. Such patients should be delivered promptly to avoid fetal injury or death. Sometimes cesarean section is required to achieve that prompt delivery. If persistent and not correctable, they represent a threat to fetal well-being. Variable decelerations are variable in onset, duration, and depth. They may occur with contractions or between contractions. They're at least 15 beats per minute in depth and last at least 15 seconds, but not longer than 2 minutes. Their onset to nadir is less than 30 seconds. Typically, variable decelerations have an abrupt onset and rapid recovery, in contrast to other types of decelerations, which gradually slow and gradually recover. Variable decelerations are thought to represent a vagal response to some degree of umbilical cord compression. As pressure in the umbilical cord increases, the high-pressure umbilical arteries become occluded. When this happens, there's an immediate rise in fetal blood pressure. 30% of the fetal cardiac output goes to the placenta, and if that flow is blocked, the fetus will rapidly develop significant hypertension. The normal fetus will respond to this hypertension by immediately slowing the heart down by sending a signal through the vagus nerve. When the umbilical cord obstruction is released, the vagal response disappears and the fetal heart rate returns to normal. If the variable deceleration lasts long enough to cause hypoxia, there may be a more gradual rise back to the baseline and some overshoot. Overshoot means the fetal heart rate goes higher than the baseline for a while to compensate for the mild degree of hypoxia and acidosis that has occurred during that deceleration. Variable decelerations, unlike late decelerations, are not caused by hypoxia, although if severe enough, frequent enough, and persistent enough, they can ultimately lead to some degree of fetal acidosis. There are a number of interventions to effectively treat variable decelerations. You can change maternal position to improve uterine blood flow. You can give IV hydration to increase maternal blood volume, presumably leading to increased uterine blood flow. You can administer oxygen to the mother to try and get some additional oxygen to the fetus, although since she's already saturated about 99%, this won't have too much of an effect. You can give an amnio infusion to improve oligohydramnios. You can decrease or discontinue oxytocin infusion to slow down or stop contractions that are provoking the decelerations. You can give tocolytic drugs to slow or stop contractions that are provoking the decelerations. And finally, you can digitally elevate the fetal head out of the maternal pelvis to ease the pressure on the umbilical cord. Occasional mild or moderate variable decelerations are common and not considered threatening. They are seen in the majority of laboring patients at some time or other, and they are more common in the second stage of labor. Mild variable decelerations do not dip below 70 beats per minute, and they last less than 30 seconds. Severe variable decelerations dip below 60 beats per minute for at least 60 seconds. This is called a 60 by 60 variable deceleration. If persistent and not correctable by simple means, they can be threatening to fetal well-being. Like persistent, non-remediable late decelerations, fetuses demonstrating persistent, non-remediable severe variable decelerations should be delivered promptly, preferably vaginally, but by cesarean section if necessary. Prolonged decelerations last more than 2 minutes and occur in isolation. Causes include maternal supine hypotension, epidural anesthesia, paracervical block, tetanic contractions, and umbilical cord prolapse. Some of these are largely self-correcting, such as the deceleration following a paracervical block, while others respond to simple measures such as repositioning. In 2008, the National Institute of Child Health and Human Development issued a statement with recommended categories for describing electronic fetal monitor tracings. Category 1 means normal, with a baseline between 110 and 160, moderate variability, and no late or variable decelerations. Category 2 means not Category 1 nor Category 3, and is indeterminate in its significance. Category 3 means abnormal, with absent variability, accompanied by bradycardia, variable decelerations, late decelerations, or a sinusoidal pattern. In communicating the pattern seen on electronic fetal monitor tracing, it's useful to use a systematic approach, primarily to avoid omitting important information. I recommend you use this 4-step approach. Start with the contraction pattern. In this example, I would say there are regular uterine contractions every 2 to 3 minutes, lasting 60 seconds. Next, provide the baseline fetal heart rate and variability. In this case, I would say the baseline fetal heart rate is 140 beats per minute and has moderate variability. Next, describe accelerations and decelerations. In this tracing, I would say there are multiple fetal accelerations greater than 15 by 15 and no deceleration.